profesionale, bashkëpunimit ndërmjet mjekëve të SHSKUK-s dhe atyre në Zvicër, në qëllim të ngritjes së avancimit të klinikës, përkrahjes në trajnime dhe për organizimin e takimeve në të ardhmen. Prandaj falenderojmë edhe përzemërsisht profesor Dr. Matias Vreider, si dhe Gastro Foundation për angazhimin e palodhur për ndihmën e klinikës tonë dhe pjesëmarrjen në këtë takim. Andaj shpresojmë që të vazhdojmë punën profesionale për sukseset të më të tjeshme. Dear guests and colleagues, allow me in my personal name and on behalf of Gastroenterology and Hepatology Clinic of the Republic of Kosovo to greet you warmly, to welcome you, to wish you successful work and a pleasant stay in our premises. Colleagues, the Clinic of Gastroenterology has organized this meeting in the framework of mutual cooperation with Gastro Foundation with the aim of increasing professional skills. Cooperation between the doctors of SHSKUK and those in Switzerland with the aim of establishing and advancing the clinic, supporting training and for organizing future meetings. Therefore, we sincerely thank Professor Dr. Matias Vreider and Gastro Foundation for their tireless commitment to help our clinic and participation in this meeting. Therefore, we hope to continue the professional work for further success. Ju faleminderit të gjithëve, tash do të fillojmë ligjëratën e parë e ka profesor Matiasi.
Good morning, everybody. So I'm happy to be here. This since 2019, I think this is the fourth time and one online meeting. And today we have just a short two talks. Hopefully I will not talk too long. Otherwise I will look to your faces and we will cut it because we want to see practice today. Yeah, this is a practice, this is a workshop. So we have after this, we have the patients, and after lunch, we will have some examinations on the porks. We have the stomachs from porks, and we train on this porks a bleeding situation or vascular clip or what else. So I think for some people they can study it under guidance of my colleague of Dr. Apri and my assistants Tanya Brunetti. So we start with the topic foreign bodies. I think this is a very common topic in your country, also as in our country, because we, as gastrologists, we are clever people. In the night, I stand only up in one situation with foreign bodies. Is there bleeding? We have time. We know from the literature. Now we have if there's acute upper bleeding, we have time more than 12 hours. So during night, I say, I will look to the stomach at the next day in the morning. But foreign bodies, this is could be a very critical situation. This is the reason why I stand up in the night. For the other situation, I don't stand up any longer in the night. So what I not can offer is this situation. This was published recently. Situation in I think it was in Syria. As you see here. In the front here you see this tool, and this was put out with a very necessary tool. Hopefully you have it also in your department. It's a metal one to remove something out. It's important for foreign bodies, especially if in the larynx. Yeah, so it's very necessary to use this. But I think this is a very difficult case. I will show you some cases of my career. So for the foreign body, it's necessary who should be treated, when and how. This is the three questions. And you see, childs are very difficult. I think in your department you will do it. Yeah, he told me, because you have not a trained pediatrician gastroenterologist. So it's a critical situation, especially in childs. And how? This is a critical time point, and you have if there's some signs, there's fluid in the mouth, you can't swallow anything, then you have not longer time than 6 hours. remember this, 6 hours is a critical situation, because I have seen it also in my career, the so-called Burhoff syndrome, rupture of the esophagus, and then, yeah, very dangerous, high mortality. So in this situation, this always I ask, you have to ask maybe in the emergency department, what is the situation? Can he swallow? Is some fluid? Can he drink some fluid? Is it possible? It's not possible. Yeah, I think you have to stand up in this situation. Yeah. So, and especially the critical situation is the child, yeah, lower than 6 years, and also we have patients, as you know, with mental retardation or schizophrenia, borderline psychotic orders. This is a critical situation. And then you have to ask, what is really the cause of the foreign bodies? You have to ask the patient, yeah, what kind of food is probably an impact. Here you see it could be a longer impact, yeah, because you see esophagitis, it looks like fungal esophagitis, candidiasis. So this foreign body is probably a little bit longer in the esophagus. So the causes of infection is mostly, you have strictures. I think it's very common also in your country. You have reflux diseases not well treated, malignancy, also some webs, some rings, and the typical parts, the upper part, the proximal ring. Sometimes you have ring in the mid of the bifurcation of the trachea and the distal part on the stomach. And then you have more rare diseases like achalasia. They came very often, sometimes underdiagnosed because of elder age. So the most common foods in our country is fish bones, especially also from older patients, prothesis from the dentists. Yeah, they're working. Yeah, I'll show you some pictures. You find some tools of the dentist in the stomach, and it's not easily to remove out. This is the situation. Yeah, and also very, very common, and the most reason to take biopsies in our country is the eosinophilic esophagitis. Nearly half of all patients with foreign body impact have eosinophilic esophagitis, the asthma of the esophagus, as you know. And this could be well treated by, as you know, by steroids and topic steroids, but we call every patient after this emergency situation, and we take some biopsies 2-3 weeks after this this impact of the foreign body, and we take some biopsies for diagnosis. Important, remember the eosinophilic esophagitis. So if we have the problem, we have to ask the patient what kind. Batteries are very problematic. Yeah, especially 2 batteries in the child. We have to move out. A big problem because of laceration of the mucosa, and maybe you get a hole in the stomach or in the esophagus. So this is a critical part. Batteries, especially in child. You have to ask: is it sharp? Yeah, what kind? The size? It is a long object. If it's smaller than 2-3 centimeters, it will go up by natural way, but otherwise you have to put out because of impactation in the distal part of the bowels, probably on the bowel hinge valves, you have a problem. So, and then sometimes it's also difficult to localize it. So it's always a question: how do you need X-ray or something before? So mostly it makes no sense to make an X-ray because most of the foreign bodies you can't see via X-ray. So it's always a question. Better you perform a low dose CT scan, probably if you have. But the thorax CT or abdominal, it makes no sense. You can't localize it. You don't know where the foreign body is. So it makes no sense to perform these X-rays in this situation. But this, just told you before, this is very important. Ask: hypersalivation, not possible to swallow any fluids. This is part that you have to think is a complete obstruction of the esophagus. And then you have to remove out the foreign body within 6 hours. Please, this is a very, very important time schedule for you. So I just told you this is very difficult for diagnosis. It is radiopac, mostly not, and is imaging really useful. So conventional X-ray makes no sin in thin metals, wood, plastic, glass, fish. So in most of the parts I told you before, it makes no sense to make an X-ray. And if you really want to do it with a low CT scan, then you get more information about really localization, and it is useful to perform a gastroscopy or colonoscopy. Mostly then you do something that's not necessary. In kids, it's problematic to perform any X-ray, so probably you have to look inside. Yeah, this is difficult, and this is also a difficult situation, as I know, since again yesterday you have not really good sedation. We do it only with propofol sedation, and in some cases you need also intubation by the anesthetist. But without propofol sedation, it's for the child or for the patient, it's a horror. Yeah, not an easy situation. So, but the good news are most of these foreign bodies will perform spontaneously as passage, and you need only in 10 to 20% really endoscopic salvage and surgery intervention. Very rare of big foreign bodies, maybe in the stomach, or I told you they move forward to the small bowel system. Then you need sometimes a surgeon. I will show you some. So this is just a memory of this treatment, conservative versus interventional. So if you have complete the emergency, latest 6 hours. Yeah, if you have emerged bolus impacted with complete occlusion, 2 maximum 6 hours. It's a foreign body larger than 6 centimeters and magnets. We have a little bit more time, 12 to 24 hours. If the diameter is less, something about 2.5 centimeters, yeah, then we have time. Maybe you can perform elective, not necessary to stay up in the night. And the small one, yeah, do nothing, let him eat, and a lot of fluid, maybe check again. It's mostly they will pass by themselves. So this is important, I think, especially for the younger doctors, when they have to call the experienced doctor, yeah, in the night, because he will not be happy to get an answer, and this is clear for you. Yeah, is it correct, Abri? So you need some endoscopic tools. Yeah, there's a lot of tools you can use. Sometimes you use an overtube. Yeah, if you have to go very often into the esophagus or the stomach, and this is useful. I think I don't use it very often in my career, but my colleague uses it more than me. So very, very important is this tool, is this balloon. This I have learned from a colleague. If you pass maybe with a wire through the obstructive foreign body with a balloon, and you can remove it easily out with a balloon. Be careful with this, yeah. But this is also useful. Then you need a lot of kind of snares and net, and a lot of other tools. You can see here some special forceps, large one. And most important is this capuchon, as you see here. It's a gummy. It's a gummy, and you put it on the esophagus. And if you go back on the endoscope, if you go back from the stomach to the esophagus, will make like a ventile, and it's you can put the sharp as you see, the fork here, and sharp fork into this gummy, and you will not damage the esophagus. Very important tool, very cheap, costs nothing. I think you have some tools. You don't have? No, it's very, very costs nothing. What is the price? 2 francs? Not more. Yeah, very easy. So this is the most important thing. Yeah. You can use also, we discussed it yesterday, you can use also special caps from the ligation. Yeah, I think maybe here. Here, you can see here.
But it's not Japanese. It's very expensive.
Yeah, this is more expensive. You use a Kosovo variant, yeah? But it's also possible. But this is really necessary. I think Tanya, we should send them this because this is very, very, very cheap. Okay, and then you have to put it out very gentle, and maybe the follow-up is still to be discussed, because I told you, you have to clarify the reason for the foreign body. Yeah, is there eosinophilic esophagitis, and is there reflux therapy necessary, dilatation, bougies, or is there achalasie to be diagnosed? So some examples, as you see here, very common. If we start in the oropharynx, you see here a classical toothpick, yeah, and this is painful. You can remove with a Magel, yeah, and typical fishbone. In older patients, think about other reasons for obstruction. Very common is a Zenker diverticle. The Zenker diverticle is a malformation because of the muscle cricopharyngeus, and some part of the esophagus will be in this part, so the pseudo-diverticle. And you can see here's the diverticle, here's the diverticle, and here's the esophagus. And you see a big part of mostly of it's chicken or something like that, and you have to put out. And after this, you have to treat the Zenker diverticle, which is not easy to treat endoscopically. Maybe I don't know who's performing the Zenker diverticle. In older patients, think always it's not easy to come into the esophagus. Ask the patient: is it easy to come with the endoscope to the esophagus? And think always about Zenker diverticle. In older patients, you find it in 1 to 2%. So some parts here, as you see, extraction also with the Magel forceps. Big chicken here. Was large, pork bolus was it? Yeah. This is beef. So this is a daily work. Yeah. Sometimes you have to put it with the endoscope in the stomach. This is the easiest way, but you have to do it carefully with experience, because otherwise maybe you have a laceration or rupture of the esophagus. Rice bolus. So, and the reason was stenosis here, as you see here, peptic stenosis. This is a typical picture of eosinophilic esophagitis with the webs. Yeah. If you see this and ask the patient, there are some problems with swallowing and sometimes dysphagia. So it could be also a typical part. And you see here, this should be removed out. And he comes very often with these problems. And recently he got this Jorvesa, this oral dispersible budesonide. As you know, it works very fine and best data, and it's now recommended by the European societies. And sometimes these people with eosinophilic esophagitis need, if not well treated, because of fibrosis, some dilatation with balloon. So but these are very severe cases. So think always foreign body eosinophilic esophagitis. More rare diseases diagnosed mostly by the pathologist is the brother of the eosinophilic esophagitis is lymphocytic esophagitis. You see these diseases only histologically by the pathologist. So also here you have to make, after you have removed everything out, yeah, and you need biopsies. So this patient came very often, you see with the age, these are always older patients. So in the older patients, think this could be some other disease. As you see here, this was radiogenic stenosis. Also you have to think about this feature. Some stenosis by radiogenic, and you have to extract here the gumdrop with a rad forceps. And here, this is also very common. Older people, ingestions with the pills. And you see, this is very sharp, very sharp. You can you can easily make a lot of lacerations when you remove it out. In this situation, it would be very good to use your kind of tool. Yeah. And this is also was a young lady here, male. He has this is metal from the brace from the dentist. Yeah, also very common. Yeah, they swallow this and you have to remove out. So more rare diagnosis. Think about some kind. This is a lichen ruber planus. It's a dermatological disease. Also, sometimes you have some combination in the esophagus. You see some mucosal defect. So if you see this, you have to think it could be something else. So the golden rule is, if you don't know what it is, take a biopsy. Mostly you're right. Yeah, yeah. Take a biopsy. And if it's a varice, it's not good. It's good, but mostly you're right. And here you see this was a rare disease, and it's also this is a rare disease of pseudodiverticulosis of the esophagus. You see these small holes. Look carefully to the esophagus in this foreign body extraction, because this mostly you can heal it with some fungal treatment, and this is a reason mostly of severe fungal infection of the esophagus. Also, this is a rare diagnosis of the Barsoni's pseudodiverticulum. So you see here this esophagus like a corkscrew esophagus, yeah, with a dilatation. And in this dilatation, you see here and here some diverticular, and the foreign bodies can be obstruct here the esophagus. A very diffuse disease, not mostly older patients. And these patients need mostly a POEM treatment. Yeah, difficult. I don't do the POEM. Maybe you have to send this patient to special centers. This is also a dentist working. Yeah, and maybe whoops. Yeah, this was in the stomach. Yeah, and you have to remove out. So be careful. Also here some removal from the dentist. It's very common. Dentists say, oh, something happened, please, and they send to you the patient, and you have to move out here. Maybe gold teeth. Yeah, sometimes maybe if you are happy for the gold. Also some parts here. This, I think this is very common. Some sticks here, metal parts. Long day without any problems. Here has a patient some pains. Sometimes you find some foreign bodies in the stomach, and the patient has never pain before. So be careful. This could stick out of your stomach to another part of your bowel system, also to vessels, big vessels, to aorta, and you put out, and you have a big problem. Sometimes you have to look carefully for this. Yeah. If you have a fistula, especially from the duodenum to the aorta, and then you put something out, it could be dangerous. So this is also some typical parts. I go through this part. So this is also very common to fire the spoon here. Yeah, as you see, a spoon to put out, you need mostly some tricks. The most important tool for moving foreign bodies is still the snare. Yeah, without the snare is the most safety tool for moving out. But in this case, it was also difficult. This was this was a tooth handle, but this how do you say for cigarettes? Fire. Yeah, fire. Yeah, here. Yeah, yeah. So this is the only example of borderline. This is only one patient. Yeah, this one patient with borderline psychosis came all over this period, over 2 years in my hospital in Zurich, nearly every week, anywhere. No, we have a lot of hospitals in Zurich. Yeah, and you find all these things in the stomach or the esophagus. Yeah, very difficult. Yeah, as you see, there's everything. Yeah, everything you yeah. You have quite the same case. Yeah. After you have also a case like this, I think so. Yeah. So and also some cases. This is a case of my time. I was in western part of Germany. So you see here body packers, also difficult situation. Yeah, with heroin transport and Very difficult, to remove out. And I had one case here. One case, he was 25 years old, body packer, cocaine, and we waited and we waited several days, but it came not out. And if it's too long, you have a big chance that it will rupture. Then the patient will die for sure. So I put it out very carefully with a domia or with a snare, and I was happy when I have removed the domia basket. Here you can see domia from the ERCP tools. Very careful. I was happy when I had removed it out. Foreign bodies in the duodenum you see here, very common are some broken feeding tube, some small things you find here, some metal. So this sometimes it's also very useful to use a pediatric colonoscope. As you know, these are a little bit slimmer and longer, for 1.60 meters, and this is also sometimes useful. You come distal the part of the Treitz ligament, and this is useful. So if you can get it in the future, or you use a colonoscope also for this situation. This I want to show our own case also. This was just recently published. This was a case of Bouverie syndrome. So the big stone of the gallbladder removed to the duodenum, as you see here. There was a big one, 5 centimeters diameter. And I have performed this electrohydraulic lithotripsy. You see nice pictures, perfect pictures, And I removed it out very often. This was a big one with a snare. This was long effort. Patient has to be intubated, Bouverie syndrome is a very rare disease and not easily to treat. So, and this is also mostly borderline psychosis, patient here with some spoons. In this case, it's useful to make some X-ray, because maybe you can get it via colonoscope, and this was this was possible to remove it out with a double balloon enteroscope, and because we know this was possible to reach it from aporal, so this was we moved it out over 2 meters out, and operation was not necessary. I think in your country you need operation for this situation. And this is, I think, the final slide for this part. Also think about the distal part of maybe sexual stimulation situation. We very often have cases have to remove out some tools for doses and candles and what else. Parts is sometimes very difficult. Sometimes you need also the help of the surgeon to move out these parts. And you need a good sedation of this patient. It's very painful, and as you see, this as for a kind to move out is possible, but most of the time you need a surgeon for this. So I came to this is a selection of the last 20 years of the only selection what I removed out, and it's just come to want to summarize. So. If you, very important as emergency case is the complete obstruction, and then you have to come in within 2 hours. If there's no complete obstruction, you have time to the next day. It's sharp pieces, batteries, and the diameter between 2 to 5. You have also time to the next day. And special cases are long foreign bodies, because they will not pass the bulb. They should be removed out, otherwise it will go on, and then you have a big problem, because to move out in the small bowel system is quite not possible, as I showed you. And if it's more distal, you have time, and mostly it went out immediately. You have to ask the patient, please tell me if you find something in the stool, otherwise maybe you need after several days also an operation. So please make a reminder for this patient. So thank you for this first part. I'm still in. I think we should have two to three questions, because your case maybe your.
I have a question first. As first, I want to thank for this presentation.
I am curious to know, do you use every time sedation and intubation?
Yes.
Every time? Because
We are in Switzerland, my friend.
Yeah, okay. It's
Yeah.
enough for me.
Yeah.
And the second, okay.
So when I started my career, and this is now 30 years back, sedation what we have done only in very rare cases. Nowadays, for such a situation to move something out, I think it's not necessary to have real sedation. Some domicum I think is enough, or without any domicum. But is it necessary to move a lot of things out, more? You have always to think, if you have no propofol, please use the help of the anesthetist.
Yes.
Yeah.
And the second, if you allow, I want to share with you our case.
Yes.
Can you allow?
Yeah.
2 years ago, we have one prisoner from north part of Kosovo, from Mitrovica, who was in prison, and he swallowed Nokia phone.
Oh.
For the Nokia. So,
Okay.
yes,
Oh. Wow.
we are here.
Wow.
Here.
Yeah. Super.
Here is
And Rima, huh? Is this Rima?
Nada.
Okay.
Bahria.
Fadil, eh? Is Fadil, eh? Not Fadil? Yeah.
And he swallowed this Nokia 3310. I don't know, it's a small one, but
Yeah.
it was functional phone.
It worked. You can call him.
Yes, and the interesting part of the story is that phone was inside a preservative.
Yeah. Okay.
He swallowed the phone inside with a preservative. And there is a
Mach ein Foto davon.
you see here. Here is the phone. This part.
Yeah.
Phone. شبكة كده.
انسلات يدرا
كوكير على.
I have to make a photo because it's so nice. Yeah.
Actually,
And then you moved it out.
I removed without anesthesia, without intubation. Yes. I just yes. And
You were in the television.
there is a phone inside the stomach. Sports.
فايل دوكس
Yes.
Yeah.
ستوب
Phone inside the stomach. This is extracted phone. It was functional. and
But how do you moved it?
with the snare.
With a
Snare.
Only with snare.
Yes, only snare.
big snare.
Because
This was small handy, yeah.
Yes, I remember it was time of COVID.
Oh,
Yes, 2 years ago.
2 years ago.
Yes, 2 years ago. Yes.
So this should be my talk. Yeah. Thank you so much. So, fantastic. It's Kosovo strange people. Yeah. The other one.
This one, right?
Yeah. So the next topic I will. We have time. Just okay. This is very good because now we have some cases. You have cases prepared for colonoscopy, and I will give you some insights about the procedures and also of the management of complication. Because there are big polyps, and it could happen something. And if you want to remove out polyps, this is always necessary that you are able to deal with the complications. It is not a good endoscopy if you need always a surgeon, for helping. So you have to deal with your complications. But first of part, if you remove anything out of a polyp, I look carefully to the surface of the polyp. And I just want to remember here, you need this classification of Kudu. You know, everybody, if you have on your endoscope, and I think probably you don't have, we perform a virtual chromoendoscopy. This is, if you have this polyp, I look carefully to the to the surface, and this is a typical part. I can tell you, this is a minimum. This is a type 2 pattern. This is a low-grade dysplasia. Yeah, I look to the crypts. the regularity. This is typical, just regulated but enlarged. This is a Kudu 3. And if you have more probably this one here, this is typical type 5, it is clearly a cancer, yeah? And in this situation, if I know and I look carefully to the surface, I'm a little bit thinking about it makes sense to remove out this polyp because maybe he's deeper. He invades the submucosa. And if it invades the submucosa too deep, it makes no sense to remove it out, yeah? Then you have grade 2 of the cancer. So please look carefully to the surface and use this Kudu classification, the pit pattern classification, as I show you, you will find it in the literature. And if you have this possibility. So this is a graduation of the colonal mucosa, the pit pattern. Yeah, so, and also the second part is you use the Paris classification. The Paris classification tells you something about submucosa. If it's only a polyp, typical with a steel, pedunculated, this can be easily treated, this polyp. But more, look to this part, the type 2A, 2C. A depression is always a sign of cancer. And the 2TC depression is mostly also a deep invasion of the submucosa. And this type of polyp, be careful with extraction of this. So this is what I think you may be looking later to this, where we discuss it on the cases, makes it sense. If it's a flat one, easy. Yeah, you need the lifting sign and we can remove it out. But always the depressed types have a high incidence of cancer, an invasive cancer. This is, just remember this, yeah. Look carefully before you do something, oh, polyp, and then do it out. Look 1 minute, 2 minutes, 1 minute is mostly enough to look really carefully to the surface, chromoendoscopy and Paris classification. And also, if you have larger one, lateral spreading types of neoplasia, we have to look to the size, to A, this homogeneous of here, is a combination. And again here, if you have a depression, be careful, this is mostly a cancer type. So if we want to remove out, we should be familiar with these procedures, with hemostasis, the types of polypectomies. Maybe we have some other parts, maybe we have discussed it, I will go over this. The tools are for hemostasis, injection needle, you need an injection needle, especially for modeling the flat adenomas. Yeah, you make a good ground on the submucosa to move out, and you need a clip probably, and sometimes you need or something else, argon beamer or what else. Yeah, but these are the most useful tools you need to remove out a polyp. So, as you know, for stopping bleeding, we have some tools. Always you have to think mostly in the situation of when you remove out a polyp, we have a situation of forest 1A and 1B. Yeah, 1A is bleeding, very severe bleeding, or only very simple bleeding. This is a situation after probably of polypectomy. So, but for this hemostasis, you can use easily these Olympus tools. The multi-functional rotator. I don't know what you have. You have single one, or what kind of clips do you using? Single. Okay, because this is cheaper. We used it before. Now we change also to single one, and we have different types of.
Some we have single, some reusable.
Because these are cheaper.
We had before.
This is very much cheaper, but now anyways we don't use it here. But it's when we have different types of the clips, you can open these branches maybe like this. We have also some. We will show you later. We have brought some devices with us. So and oops. So oops. What is really emergency endoscopy is this. I had time to make this video. And if you see this is what kind of this is 1A bleeding, huh? And then you need carefully, you need the clip. But you see, we have done in this situation not only a clip, you have seen maybe at the end, have not the whole video, we have performed an Ovesco clip. You have seen it, yeah. Yeah.
But because of fibrosis, it was very difficult.
Yes. So if you see such a bleeding, your pulse is also getting a little bit higher. You have not much time. So I have performed first the clip, and then it was not clear, and then we have put Ovesco. But nevertheless, today I would wait. I would perform first an Ovesco clip. Yeah. So APC is also very useful for coagulation, not of bleeding. Also if you have some on the rand, on the border of the polyp, you have maybe some rest of polyps. You can use it, but you can use also the snare with coagulation. Yeah, this is the only kind of coagulation, but useful for angiodysplasias as well, Gave syndrome, as you know. Do you have beamer? Not yet. Okay, I will pass it, but this is useful. I think with the Vittorio, with this erbotom, you can use also argon beamer, and argon is cheap. It's very cheap. Yeah, I know, but to buy it is not too expensive. Yeah. So this is our more sophisticated tools. You can use so the endoclot systems. This is sometimes you're using this. Mostly we use this type from the company of Cook, and this is a kind of polysaccharide, and you can put it on the wound, and now it's also established for 1A bleeding, as you see here, and makes a good healing of this drug. As you can see here, for example, this was a tumor bleeding of cancer, and then we put this saccharide on this, and stable. But for severe bleeding, you need and also for closure of holes, and it can happen if you make a polypectomy. We're using the clips, also better the Ovesco clip, and we will use it today. We train you, and I think this makes fun. Yeah, because you don't fear any longer the surgeon, and he comes to you, do, you have to make a hole. No, you can close it by yourself. Yeah, this is very easy, and we try to show you that different types and sizes. We'll discuss it later on the workshop. Okay. Do we have an anchor with us? Oh, we missed it. In special situations, you need this type of anchor to put some tissue in this inside of the clip. But in bleeding, I never use it. I only use it if I make a hole. Then you need it. So maybe we missed this. Maybe we have it also. It's in the tool. So here I show you video opfolge. Oops. No? A video from this clip. As you see here, there was also very, very severe bleeding, and there was a case of my time in Zurich, and there was here you see it's a big ulcer with a bleeding. It was an old patient, I think more than 80 years old, and in this case you're looking. It's very easy. You go in front of this ulcer and you're a little bit sucking at this time. Here you see I suck, and then chuck, you see how now it's on this. This is on the distal part of the bulb. This is very easily. You go just undercut to this bleeding part, and this is very easy. It's much easier to use than a clip, I can tell you. If you have done it several times, it's easier. Yeah, and you're safe. Yeah, you're safe. You can go. This will never bleed again. Never. You have go after this bleeding. You have to go through this part. Maybe that you not close the hole as you see here. That you close the bulb. Yeah, and that would be pity. Yeah, but you have to cross this Ovesco clip. So just 5 minutes to the end of the part. What kind of polypectomy? Which kind of snares we are using? As you see, we use the erbotom. This one is a little bit newer generation. We have different types of snares, but the most important tool is the electrosurgery unit. How to use it? You can do a lot of things wrong, so I recommend always to bring the company to you and that they make the regulation what is the best for you, because otherwise you have a big problem. And it's not comparable. This type of airbotom is not comparable with the other tool. So every electrosurgery has a difficult cut and coagulation computer system. So please always ask the companies, yeah. Which snares, as you know, we have a lot of type of snares and size. And nowadays we're using for the smaller polyps, smaller than 10 millimeters, only the cold one, mostly the cold one. It works fine. Also for larger one, you can use this cold snare, and the data are very good. You have no more bleeding. So in this type, you see typical cold snare, and it's easily done. Yeah, it's also much faster. But sometimes you have to look, if you want to have a histology, you need a special cavity to collect it. We will show you also what we are using for this. And this is very easy. For larger one, you need mostly injection, so the mucosectomy. So we inject a lot of natrium chloride. This is most important. Some cases we make a mixture with indigo-camine, with color. That you see, do you have indigo-camine here?
We make, yeah. We don't buy original. We make in the biochemistry unit.
Yeah, okay.
We make for us.
So we can use it later. We can use it.
Today I don't know if we have it because now we have NBI, but we used before. When to write NBI, now we are using NBI more than chromoendoscopy. No, not for chromoendoscopy, because the special one is if we make an injection here, the submucosa, we want to be sure that we don't damage the muscularis. Yeah? You mean the solution to
yeah.
make with indigo-camine?
Yeah.
Yeah. But I'm afraid to have from biochemistry because it may be not sterile. And we cannot buy the unit of indigo-camine that is sold in Europe. That it's in special
ampoules, yeah. Yeah.
And without ampoules, I cannot solute the solution.
Yeah. Mostly you can, yeah, but you.
Do spreading when we don't.
But you can use it. Maybe you make one bottle. You can use it several days.
I'm afraid, to be honest, and so I do not use.
Yeah. So but be careful. No adrenaline. This is a rule. Yeah, because our adrenaline gives you a false security, and also not too much saline. So it depends on the size. Sometimes you can cut something, and we will show you later. We will discuss it in these cases how we do it that is safe. But adrenaline for injection I use only for pendulated polyps, never for flat adenomas. Never do it. You have a higher risk of perforation with the adrenaline. There are good data I can show you. And for the big vessel polyps, also again, I told you, look to the Paris classification, also pit pattern, and then decide is it useful to make really a mucosal resection, endoscopic mucosal resection, EMR, and especially as you see here, you want to get this situation, yeah? Flat and never do biopsies before, because the next one will have more problems to remove it out. So cut it or let it. Yeah, this is my golden rule. You should look carefully that it's possible to remove out the polyps. Otherwise, send the patient to another guy or send to surgeon. Okay, so this is only a slide. Maybe the cold EMR is now more popular also for bigger polyps like this. You can use easily with a snare in piecemeal part, and you get a really good result of this properly serrated lesion. So, and here you can see we injected also here this indigo-camine. You can see this is a muscle layer. This is the reason why we're using this, that you are sure that you are not on the other side, but you have removed out every tissue. This is what I mean. Injection with the blue one with indigo camine. And for the pendulated polyps, yeah, you see here this. I always using adrenaline for this. I never use endoloop. Yeah, I don't like it. Yeah, I know. You told me yesterday because I'm much faster to move it out without endoloop, and then I put. But nevertheless, important is always injection. Here you see of the stem with adrenaline. Then in this case, we had also this. Here you can see the part of the endoloop, and then you can cut it easily here. And you don't need a clip after this. I put it out without endoloop, and then I make a clip on this. Yeah. So it depends on your feeling and your experience. The data are a little bit better with a loop. Yeah. So this is the final part I don't want to show you because ESD is only for advanced guys. I do it also not any longer in my department now. I've done a lot of ESDs, but it needs a lot of experience also with the stuff. And we have not enough cases, so I don't do it any longer. Before I had done a lot of ESDs in my life. And you see here also in the stomach ESDs, and then they have a completely part of this part of but it needs a lot of tools, as you see here, special knives, and this is very, very, very expensive. And don't start with ESD in your life. Yeah, it makes no sense. So at this part I want to end because the other things we will show in live and with on a workshop by our hands. And thank you for your attention.
Again, I want to share our experience with subepithelial lesions. This week we performed one endoscopic mucosal resection with ligation.
Yes, it's all good. That's good.
There was a lesion,
yeah,
about 11 millimeter in mucosa under the US.
Where was it, in esophagus or in colon?
The distal part of stomach.
Okay.
Near the pylori. First, as you know, we give
injection.
After that, we cut a band, and after band we cut it. Patient is okay. Today is good.
This is a very, very good way. In stomach, this is not so often used. Very, very useful in the esophagus. But a tip: don't use injection before. Only suck and cut. No injection. No, and especially not in the stomach. Yeah, it looks fine, but in the stomach, as you know, it's not easy to get a good ligation. Make only, yeah. And the esophagus is a good deal, but never with injection. Yeah, never. Okay, then you can stay, take a short break. My friend Abri and we will go to the theater. Yeah, and you also, and see us later. Okay. 50 minutes.
15. That's mine. Svislanta kemi profesor Matiasin dhe motivacionin nga Zvicra për të bërë disa asistenca në intervenimet tona endoskopike. We are very pleased to introduce our very special guest, Professor Matthias from Switzerland, and Sister Tanya. They will help us to do some procedural endoscopic procedures, some different cases. We are already 4 cases prepared to have during this 2 hours session. First patient, we have a male around 60 years old after colon resection because of colon cancer. After screening 20 months after the surgery, we have done a screening and we noticed a very big polyp, peduncular polyp, around 2-3 centimeters, adenomatous polyp, and we scheduled for today to do removing and polypectomy.
Thank you.
We have done previously, it's very important, we have done complete examination till the cecum. So this was only one residual polyp, but maybe it was missed before the operation.
Okay, thank you.
Patient is under sedation with Dr. Albani, who's our best friend here, who help us in different cases.
Hello to all of you.
E përshëndesim Dr. Albanin për ndihmën që na jep gjatë tërë kohës.
Ja që flasim anglisht, për hatër të musafirve në nderu. So we are
Our preparation is all okay.
Yeah, we told the Professor Matias about difficulties with preparation, ball preparation, because we have only one or two foreplans and one other solution for preparation, and to be honest, we are not so happy in our daily practice. But fortunately, this patient is clean.
And this patient was examined by you before?
It was examined by me. Okay. And I think now.
So you're performing only endoscopy on the left side.
Left side.
Sometimes
Yeah. Sometimes we remove, depends of the procedures in the supine or prone position. And
Please can you tell us which kind of preparation you use in your practice?
Yes, we have three types. If I can then. Nowadays we switched 3 years back to Blenvue. There's only 1 liter in the splitted doses. Half a liter on the evening, and half a liter in the morning. It's only 1 liter. This is and the bowel is very clean.
Are you happy with?
I'm happy with this, but the patient not so often because
it's a polyp.
it's a small
It's
polyp.
1 month.
But this is not the. I
No,
think
the bigger one, it's above this one. And what I use recently, I use water irrigation, and it helps me to go to the second sometimes. It's very, very useful.
Do you need water or no?
Do you have water?
We have here,
Where is the water?
Water is a little but it.
Because it's also very necessary.
This is the machine that you brought. You gave to us.
Okay.
3 years ago.
Okay.
It's an old one, but
But because your instruments are not.
not fitted for this one.
So you can use this, huh?
We can use maybe,
But this is very useful because otherwise. Wenn wir jetzt ein bisschen nah von dem Monitor, gell? Hier auch? Oder ist das, also mit der Brille kann ich gar nichts sehen mehr. Ist okay? Ja, für mich geht das jetzt. Meine Fernbrille.
Ma ščipat borku.
So the deeps of you are still in the Sigma, I see.
But it's very specific and very hard to go.
Do you use Buscopan?
No, unfortunately, no.
I don't like it. I just ask you. I know some colleagues. I never use Buscopan, never, because yeah.
No, I
But you.
in Istanbul we use.
Yeah, some colleagues you're using it. But but do you use only oxygen or you using?
Only oxygen.
Okay.
Another oxygen.
Oh, there's a polyp. Here's a polyp. So this is a polyp that sits in about 40 centimeters in the mid of the sigma. And what kind of operation did he had before? Left side hemicolectomy or what?
Left side.
A bit crazy, yeah. Why did you? Okay. Because it was obstructive cancer, probably, and
It was because of windows.
it was okay.
And they didn't do.
How many years ago he was operated?
1.5.
Okay, so.
It's a typical, wonderful polyp, with erodated,
Big stall.
yeah, with a big stall. I think this is a good indication for ligation, very good indication. This is a good, and he's so it's.
Pattern is typical adenomatous polyp.
I think it's 3-3. So you. This what please. This is what I wanted to show you. Please careful. Go on the surface of the polyp. Here's also diverticles.
diverticular. Yeah, okay. That's okay. Go back. Go back. Yeah, this is the one.
One big and smaller one.
In this
that I
one,
missed
this
to tell it.
Okay.
Yeah, it was not.
So a lot of diverticular he has, and is bleeding. I think so. Maybe
No, it's not bleeding because NBI.
switch.
No, I switched
Yeah.
to NBI. No bleeding.
Okay, but this erodated. Did you take some biopsies from it? Why is it
No, I
bleeding?
didn't take because I planned to remove it all.
Ah, this is a very severe polyp.
Very severe.
Yeah.
And he had anemia and
Make again. Yeah, maybe this was a reason why he was bleeding. Yeah. Make please again the chromoendoscopy.
Yeah, just to make some washing.
If you will see this kind of
Jetzt
polyp,
machen wir mal.
Not NBI wash.
Maybe please fix it. If you see here, this is 4C. I think this is a high-grade dysplasia.
Please.
This
It
will
can
be.
be,
I'm
it
sure.
can be.
I'm sure that this is a high-grade dysplasia.
this biopsy,
One bottle of champagne. If you like histology, this is a
One champagne,
okay.
may I ask something? Is biopsy mandatory here or no?
No. Do we have to remove out? And the endoloupe is a very good indication.
A kuptut, do të thonë biopsia nuk do të më marrë këtu, kjo do të më hjek. Okay.
Yeah, it's very warm.
Fitore,
Very warm here.
po na ndëgjoni.
Shumë e qartë, po e kuptum profesorin, që bëhet fjalë për high grade dysplasia, kështu që duhet me u largu me njëherë.
Okay, as Paris classification, this is one.
I think this is a one Paris 1P and Kudu 4. I think so. Kudu
Sipas
4.
Parisit 1P dhe Kudo 4, Kudo 4. Çdo herë do të duhet secili polit do të duhet të klasifikojë.
3S to 4. I'm sure that this is a high-grade dysplasia.
No. What is important, usually when you cut a polyp, it's very useful and very important to be a 6 o'clock position, not up in the 11 or 12 o'clock position. So now we have or to change position of patient or to rotate the scope and to bring in the 6th position, in the 6 o'clock position. This is the best way to remove the polyp.
Maybe
It's very important.
Very important.
Very important.
Otherwise, it's not possible to
not,
to put the loop on this.
After if any case of bleeding, it's very hard to inject.
Yes,
Injection
this is a good
needle.
one.
Yeah. So you think to put straight envelope
Yeah.
or to put some adrenaline with
I would start with a
on the
because if you make the injection, the view will be worse. Yeah, I would start with a loop. Yeah, a good loop is in this situation best what you can do.
Tanya, what do
Tanya,
you think, Tanya?
Tanya,
You need something else or what do you think? It's a
Tanya
good
likes.
position, it's a good
Tanya
position.
ich mag es nicht. Ich mag es ja auch nicht. Da soll sie doch machen.
Professor Matthias, one big obstacle is also because we put air insufflation, not CO2.
I know.
And if take longer, I always afraid
Problem.
of abdominal pain, not
I know.
discomfort. I don't like patient to suffer after
You
polypectomy.
need CO2.
Later on, when we do more advanced procedure without
Yeah.
CO2, it's very
It's painful.
difficult,
It's
to be
painful.
honest. Very painful.
I'm sure.
And then I think you use only the Kudo. You use nice classification?
No.
Only Kudo. It's enough.
It's, Kudo is also okay. If you use nice, it's more common in the stomach. Yeah, but I don't use it. It's not established as a moment. But in the polyps, I want to have the Kudo classification. Yeah, I know.
To change the position of patient.
Yeah,
you think it's
can,
okay?
yeah, I can hold. Shall I hold?
You think
Mach du das, mach du das mal.
it's okay?
Yeah. It's okay, should be okay. But it would be better in the 6 o'clock position, yeah, but it's not possible, I think so. Otherwise, the patient, we have to turn the patient on the... So it's good. So it's fine. Okay. So we have also support by Rima, and she will help us because this is a difficult polyp. For good preparation, we just talked about the oxygen. Oxygen is here used and is, for insufflation. And if the examination is longer and getting longer and longer, patient will have pain. So I would recommend in the future also colon dioxide as management. So it's a very good position.
As I said, we have problems with CO2 and with argon because.
Why? Yeah, I think
they don't know
it's not no production here, but probably, yeah. You have got it from outside. But this position is very good, and but this is a long coloscope I have seen, so it's a long way, yeah. No, nothing.
CO2.
One bottle, I think, is about 500 euros, and you have 2 years.
2 years. And CO2?
It's produced from
Sample system.
I think it's at 50 euros one bottle. So that is expensive. If you have the number of patients, it's getting, yeah, but argon is cheap. So you see, that he's a pendulating polyp. I think the size is 2.5 centimeters, yeah. And very good. Abri is a very good one, huh? I think so. If I come to Kosovo, I would always be investigated by him, huh? Because I need again also colonoscopy for screening. The problem with the loop, as you can see, I don't like it because it is flexible. And if there's not much space between the polyp and the wall of you have always problem with this flexible loop. But now you're getting very good, very good. You're as deeper as you can would be better.
It's important not to cut in the top of the
Yes.
head of the polyp.
Yes.
As much, shorter as much.
Yes.
Is a 1 centimeter
Yeah.
above the
Would be better.
colon.
Would be better
Yeah.
because da hinten hängt er noch drin. Da hinten hängt er noch.
Okay, good.
Jetzt it's coming down. No, you're losing. This is the reason why I don't like this loop, because it needs too much time.
Yeah.
So I inject it and then I move it out and then I make a clip on it.
I like very much because
You like it very much?
I feel myself.
You feel better?
Yeah, this is better because.
Yeah. And the data are a little bit better with rebleeding with the loop. You have less bleeding with the loop system than with the other. Yeah.
There is a function by surgeon. It's very difficult to work here because
People are out of the town. Yeah.
usually anesthesia is not coming every time. And there is another problem with the Kosovo because
Ich glaube, er braucht ein bisschen Assisten.
No, the scope is small. It's better for me, but I don't know if I... Okay, I will put it here and I cut it after. Okay, better like this. Kërkoj falje pak për vonesë, po është pozita e pacientit shumë e vështirë. It's very difficult position of the patient. And hajde, tërheqe pak. Tërheqe. Ka dale. Prit. Alo. Edhe pak. Prit. Okay. Jo, s'man shek. Edhe pak. Prit. Okay, here. Okay. Hajde, tërheqe tash pak. Po, tërheqe. Ka dale. It's stuck in the head of the polyp. Hajde. Po, prit. Jo. No. Wait a second. Yeah. Very. I do this usually very fast. Fortunately, when you have gas, it happens. But really, No, I don't think
I
so.
would, let's move the page. I always like position just a little bit.
Just a second. Just a second. Just one more minute. Just one more minute, please. Just one more minute. Osman, çevir. Ha? Omşela? Bravo. Kadar.
Haydi Arbor City Menier Yancel.
Oku. Haydi. Haydi.
Ja, ist gut.
Haydi. Good. Now you will get blue. Okay.
Now it's good.
Okay.
Now it's good.
Haydi.
Bravo.
Of course. Wait a second, please. Okay. Wait a second. No. Now I will suck something. No. So, gjithmonë e palponi stomakun, barkun, për me pa a ka shumë ajër. It's not good to have too much air in the stomach and abdomen.
Apo në ndigjon, Arbor?
Po.
Which kind of put it out and you have a clip in for security. Would you do that?
Далее.
Okay.
Okay.
What size is it?
Soft. Go. 3 centimeters. 3.
2, 3. 25. This is more.
Bigger one. Next proper call for the No. For small one. Let's be up here.
Po, Arbor, shumë mirë, shumë bukur, shumë shindur,
Me bojën do katë edhe...
shumë bukur.
What's easy to see the size of the stair on the air. They had that problem. What kind of lima? Excessive
But where is envelope is not here. Ah, it's here. Okay, it's here. But
aty është. Aty është.
Bishti,
Don't
bishti, bishti.
worry, be happy.
Okay. Ați mă mai cu șpina?
My friends, I don't like anesthesia.
Pas ka dhe divertikui, disa divertikui kjo.
But don't forget, it's not a small polyp. It's big.
It's a big one.
It's a big one. It's not.
But now you're in the position. Yeah, in a better position. Now it's better.
But also, it's the neck of it.
Put his
Just
knee
to go
out, put his
above.
knee out, and
Let's see. Give me.
there's also he's a laparotomy, maybe.
Adhesions, this kind of.
And as you see here, bowel preparation and light is not optimal. Yeah, it's not optimal. Yeah.
We have Ovesco, Professor Matthias.
Yes. What do you have?
Oh, let's go. Let's go.
Yeah. But we don't need Ovesco in this situation. Yeah, I'm sure.
I hope not. Eu não sei, chefe.
But this is nice that you give us some fortune and that hope. Yeah, this is very important situation.
Yes.
So now it should be better. Okay, you out?
Yeah. Take it on.
Endolupit përzir, i kështjel punë për këto. Aida, më shek kjo endolupit I përzin punë, përzihet me asja dhe
Për
problem.
ato profesori tha që nuk për pëlqenta, po. Nuk për përdor ke, profesor Matias.
Shumë e meshme, bravo.
Të kam shak ty.
E ke rronë për ne, bravo. Endolupi, po thamë.
But you know, it's in the column descendant and sigma. It's in the flexure where it's where it's not. Yeah, where it's. Yeah. Chile.
Okay, now.
Aida.
Pamjen e paska bajagi ashtu që mund të
Aida.
kishin marrë urnarbër.
Ka spazma shumë edhe
Po.
problem.
Po vrehet.
Spastik shumë.
Edhe një polip shumë I gjatë, me ndryshime, sigurisht mundet me qenë ma ka alteru ndoshta edhe,
Po, është.
me malignitet.
Po, ja, malignitet.
Po tush, ha? You don't think?
No, it's not malignant.
Maybe it's high grade dysplasia.
Maybe, but.
And now you can see why I don't like the endoloop system. Because it's time consuming, and so I feel much better if I have time to close the valve. Yeah.
Okay, good.
Yeah.
Well, next time.
Yeah, this is always,
Okay.
if they have the clips, yeah. But this is a good indication for endoloop. If you ask the people, most of the people would say endoloop is a good idea, yeah. But no, it's okay. Looks very good. Looks very good. He has a snare now. I think it's okay.
No.
Snare is enough. Snare is large enough.
It's large, but it's not insuflating. You see, I'm very spastic column. Very spastic. Stand back, Hitchka.
Jak szanowny pozytywny, to jest na raz Josh, co tam tyle?
Yeah, but you give too much air. This is the problem. And if you give air, the column will move. Yeah. Okay.
Ale my položky na místě teďka. A já stejná prava. Stejným kontem střílím.
Ještě je tak.
Can I help you?
Okay, try it. Yes. Just one more time. And
If you don't, I will change. Yes. Now.
okay. Do it. Take it. Do it. Do it. No separate. Just one. Okay. Keep it like that. Okay. You can try it.
Because
It's difficult.
you're getting tired. I can see it.
I know. I can ship it.
Doktor Albana, spate ndonjë ampull spazmex a diçka? Po na stena, po ti duhesh me pas.
Kyllä mä preferoin praktiikan në vetë. Në Istanbul kemi përdorur mjaft, domethënë se e nal peristaltikën edhe
Ose buskopan.
buskopani thjesht, po.
Po s'ka. Qtash je mirë. Bravo. U kry.
No, close. Close.
Now we will cut. It's very spastic colon, and this is
Very thick column. Very thick column. And very spastic.
You have to close. It's a problem. You have to close. When I say cut, or open or close, yeah? Jetzt wieder wieder anfangen. So my Albanic is too bad, yeah?
Okay, you can go. Okay.
Okay.
Please hold. Fix it.
Or we can take it 15. Also 15. Very slow.
Ich hab's jetzt mal ganz auf.
Nochmal auf die Seite. Den Tisch ein bisschen weg. Besser. Komm mal, mach mal die Schlinge auf. Das ist noch ein bisschen groß, wie das. Ja, das ist ja viel zu groß.
Das ist eine 30
Viel zu groß.
And when it's very large stairs, sometimes it's very difficult to remove.
Barber, Lina. Okay.
Go back for lunch because maybe this is not your time here. Stop. So, now hold it. Very fixed position. Jetzt, wo ist das Ding? Tritt.
An den Dashkat.
Jetzt, wir werden jetzt cutten.
Okay.
Gut, fest zu, ja?
Ja, ist so zu. Stop. Okay.
Okay. It's moved out. Okay, let's go. Very good, excellent.
Yeah, we look
No,
for.
no, no.
Excellent.
Let's see. Let's see.
Let's
Some more. Okay.
Go aus oder noch nicht?
Okay, okay. Okay. Excellent.
Congratulations. Kukry. A da ne me vendos diçka? Klip?
We have some residual tissue here. We have to remove it all around, you see?
Yes.
But it's removed.
Very good job.
Bad position, really bad position. Very bad.
Auf. Auf. So. Ja.
Not flexible.
Oh, thank you very much. Very Është një kolonoskop shumë i vështirë, a?
Very difficult.
Dhe aparati është shumë stiff, është shumë i... Very hard to handle this.
Kryesore është mirë, është largu. Bravo.
kommen wir zum Gel. Sich noch aufhören.
I want to remove out the last part. But yeah, we have to do it.
And we have only one small project that we can remove.
Nothing easy for it. So we have something. How do you move this polyp now?
With snip.
You remove with snare, yes?
Try to suck it.
To suck it and to
Because there's a bad position here.
sucking and going down. Sucking and going down.
Because this was such bad position over there.
Muove.
Bravo!
One part, it's only one part.
You can see not always a good decision. That's what I said before. I don't like the loop because of this reason. Yeah? It's much easier to move out. But I thought before, if you make a vote, I think 50%, 80% would use a loop like PIQ, and only the minority would use no loop like me. Yeah. That's my experience.
This side. And the scope is bent.
That makes it difficult to. That is what
Very
surface on
far. Very far.
the surface on the wrong side.
Hello. My classes are damaged last night. Because he has a diverticular disease. He has a diverticular disease. He's very bad prepared as we see here also, yeah. So I go a little bit back. And what just to see here was a loop. As you see, a loop can be
It's in the right side. Around 1, 2, 3.
can be clean something. I can't. Wo ist er denn?
Denkt hier unten. 7 o'clock.
7 o'clock now.
But it looks nice. You're satisfied? Satisfied?
I think it's fine.
It's fine.
I think it's very good.
I would.
Excellent.
I would.
I will check after.
It's very good, Arben.
Other one.
Thank you to Vesco Clip. Congratulations.
mesothelioma, I will reject and remove the
I think after this it was good to show the difficulties also with the endoloupe. It's a good story, but we had more problem with the loop, as you have seen, and we used also the wrong snare. It was too large, and the polyp was smaller than we believed. And with a large one, it was difficult to come over the polyp. It's not tough enough. So, but the patient is happy. You have seen, maybe Abi will check it again in 3 months, because there was another small polyp a little bit distal, and then so we are happy that everything's fine. In the meanwhile, the polyp will be investigated. Okay, next page.
Excellent. Thank you.
No, I mean, before.
We are happy the patient survived. Next. Okay. So some questions from the audience. I can't understand you.
Okay, no, thank you. We
Yes,
watch
okay.
the case number 2.
I'm still waiting because I don't know the next case. They're
Okay.
coming. But I
Dr.
think
Fadil
was
have a
little-
question.
it was a little bit long, as you have seen, and we have also seen that there's some equipment. It's not so easy. But the major point was that we used first the wrong snare. The snare was too large. As maybe you have seen, then I changed to a smaller snare. Then it was easily done. And the second problem was really the patient's bowel. The operation, it was fixed a little bit, the sigma. What else? I think I don't know really the operation, because I have seen a lot of rest of colon. I think this was only a sigma resection. So this was not really, I think an oncological resection. Yeah, otherwise, maybe you should be also asked also the surgeon what has he done before. Yeah, I think this was not an oncologically done resection, because the rectum and most of the parts of sigma, and we have seen a lot of diverticular. I am not sure what they have done. Okay.
Thank you.
The next patient is not able. Give us 2 minutes, please.
Okay, dear Professor, Dr. Fadil have a question.
Thank you, Professor Matthias, your staff from Tanya Hospitals in Switzerland. We must have the grateful for your invitation and to be here, to have here your experience, advanced endoscopic to see but I have two questions. First of all, it is very important, the complication of the large polyp can be bleeding and perforation. It is first and the second, it is very important to say that patient has 2 or 3 more diverticulum. What do you have the experience with the inverted diverticulum? You can have done the biopsy or polypectomy, it is a perforation. In your experience, in your hospitals. And in the end, I finally need to say your effort, your benefits, your donation for all the time that I have done. All people is very grateful for everything you have done for our clinic, for patients, for diagnosis and therapy. Thank you very much.
Fatih, I did not understand really. It's because it was around me a little bit loud. Did you understand the question?
First question about bleeding and perforation. Can you repeat, please?
Only short question, not so much text.
2 major complications after the polypectomy are bleeding and perforation. It is first question. And second, do you have the experience with the inverted diverticulum?
What kind of?
I am clear, not?
We don't have inverted diverticulum here.
What is this?
Where you read this inverted diverticulum?
It is very rare. It is 0.7 cases in literature.
Inverted diverticulum. We don't have here.
He speaks
Diverticulum.
No.
Professor.
About inverted diverticulum. It's a very rare case. It's not connected with this polyp case.
No, it's
different case, different.
I never heard this terminus technicus. But I never heard it. The complication rate after this loop, this was the decision to use a loop is very rare. You have less than 2% rebleeding rate in this large one. This was a reason. So this was a reason. Yeah. So now we have resected. As you have seen, after the time, no bleeding. So I decided also not to make a clip on this. So I think this is well done. And my colleague Arby will reject this case in 3 to 6 months. Because there was another polyp, you have seen this, and time was too long now. Yeah? And it's also good possibility to check again the polyp ground of what we have rejected. So I think this is a good decision now. Yeah. Sometimes to stop and not to go in another complication, because you have seen this was really difficult case for the equipment you have, yeah, and the decision and all the environment. And also live demonstration is an ethical reason to stop when you are finished, not to overdrive anything. Yeah, and I also in normal situation don't do things in live presentations you never have done before, never.
Ju falenderes,
Thank you very much.
falenderit shumë. Apo vazhdojmë me rastin e dytë? Kur jeni gati, fillojmë.
E kemi një zoj që ka qenë shtrirë në raportin tonë, ka qenë 305. Ajo ka prej 2006, 15 herë kishte në Beograd, i kanë bo dilatime, njerë me 8 mm, mandej herën e fundit, i kishin bo me 16 mm dilatim. Po kjo ishte interesant, e ka një anamnes të konfuzën, nuk të regon a ka përdor diçka, sa është e mundur që me gazat luktit janë bo, ishin e tash do cikatrik se ka në pjesën për gjatë luktit. Ne tentum, herën e kaluar tentum me 12 mm, po është e pa mundur, nuk depërtot fare, bile pa të mlanë me qëllim që kur të vinë të shojmë, a mujnë me bo diçka jo, edhe është një femër 49 vjeqare, shojmë që ka mujnë me bo.
Faleminderit.
Keni ndonjë pyetje tani ajo, po mërzitin e ajo?
Jo. I kemi lënë rastet më të rënda.
Ju ullin në këmbë do të vënë bravo, po. Sur parchapando, tout un
Present the next case.
Okay, as I said, there is a female, 49 years old. She came 1 month ago at our department for foreign body. It was part of meat, yeah, foreign body, yes. And after that, we revealed stenosis at, I think, 36 centimeters, and distal part of esophagus. There was a stenosis, and at the time it was impossible to go inside of stomach. I tried 3 times with balloon of 12 millimeters, but it was impossible to go to dilate this part. She has something confused anamnesis. For at least 15 years, she went in Belgrade and she underwent several times, at least 15 times dilatation of balloon. First time with balloon of 8 millimeters, and the last time with balloon of 16 millimeters. And as I said, she has dysphagia, and we'll try to do something. We wait our colleagues from Switzerland to take their ideas what to do with this patient. I think that surgery is the only solution here, but we can see. Acum
Po, doktor Skender, pa problem. Të shohim se çka mundet më bote kjo paciente.
Po, shohim këtu.
Rasti dytë.
Maybe you see here the bushes.
Yeah. Yes, we see.
So we will see what we have all kinds of sizes, so it should be possible, yeah. And my nurse will assist me now, and probably they have to use it, yeah. You see on the bushy here system, we will show you later, but you see here, maybe there's some marks. You can see 20 centimeter, 25, 30, yeah.
Yeah.
For example, here, the bigger one, we have a bigger one here,
It's also important that you see here the size, the French, and the centimeters. It's 51 centimeters, and here you can see again the centimeters from the distal part. If you know the stenosis probably is maybe in the mid centimeters, then you have to go minimum to 45 centimeters. And then I'm switching slightly in this way.
Without fluoroscope? Without fluoroscope? No need for fluoroscope, huh? Because we don't have here today.
Here in this case, it's very important that we get a very good position of the wire, the guide wire, because here it's possible to throw wire, and also for fluoroscopy. This is first, you will see it in the fluoroscope. Yeah. So, but you can. Sometimes I use it without, and sometimes I use it with fluoroscope. We will see. Because balloon probably is very hard.
Very hard.
It will not work with a typical balloon. There's not enough power. So the push is still very, very useful. Okay. I hope you put
Okay.
I think that the rule is to make available communication.
Po ju ndigjohim, doktor Skender, po nuk po ju shohim.
Qeni shumë me pobre.
E tash, na ki rregullu tash.
Shumë bukur. Tash po ju shohim shumë mirë.
Otherwise, you would close from eyes and see anything. So how much did you pay? How much?
32.
How much? 60 minutes. Sure. 60.
Wait a moment.
You practice.
Normally we start with 20 to 50, just in the way, half minutes, then we gave up to 120. This is
Every time. I know you are in sister of endoscopy.
No, not by my nose.
I know, yes. Jo. Sono tanto faccio molto adult bedon anesteziato sedazione. Falinde. So, you see, I'm not able to understand that. You can see now some different mucosa of esophagus. It's corrosive, it's not corrosive.
You see
Yes,
fibrosis,
you see.
you see a lot of fibrosis.
Yes, a lot of fibrosis here.
Yes, or maybe did you take some maybe it's some kind of Lichenruber. Did you have done biopsies?
No. As I said, she underwent in Belgrade for
You see
50
here,
times.
you see a lot of problems here.
And she denied that
Here
she
is
used something.
very difficult to pass.
Yes.
So I need a wire. So the stenosis is about, I think 5 millimeters, 5 to 6 millimeters, not more.
No, it's
And the indication is now we will make some very softly perform a bougie, because this is not a good indication for balloon. Not a good indication. It's too much fibrosis. And then after this we should take some biopsy. You know the diagnosis. An idea. This that you see here, this is a special wire.
Only for bushes, huh?
Only for you feel on the top it is.
And you go to duodenum or
No, we
just outside?
we put it in now in the stomach, hopefully in the stomach, and then we will see. Not easy because in this case I would like to have some fluoroscope. Yeah, as you see here. So now I go back.
And you push it fire.
Yeah.
while now on cilantro.
Well, I don't know, I hope so. So one has to see the wire normally, yeah? And be careful, the wire is not damaged, yeah?
Yeah. And have you any orientation here?
No, normally you need X-ray. So on the wire you have no. So, okay. And now, okay.
And you have X-ray fluoroscope in your unit?
Yes,
In your head or?
under my guidance. So now we take the 7 millimeters. I start with less invasive. What is the size of stethoscope? 10 or 9 millimeters?
9 millimeters.
So we start with 7 and only 2 millimeters. 7, 9, 11 in this case. And then I will check it again. So always start less one, because 12 was probably too much.
No, it was 12 after its inflation.
Yeah, but he has a problem over the whole. There's a problem. I think it's all over a longer distance fibrosis.
I am not able to understand the etiology of this fibrosis.
Yeah,
Because
after this we will take some biopsies.
she denied that she used something.
Maybe it could be also some injection of some
She denied everything.
something to the.
Yes, yes, yeah, I asked her, but she denied everything. Okay.
Innen drin muss gar nichts machen. Der Draht geht einfach von alleine. Sieht so aus. Also eigentlich muss es tief nehmen.
Dr. Skender, tash jeni tu pregatit për buzhim, a?
Ja shpini për Nikeli kemi shpije,
We start with the 7 millimeter one.
Right wire, 10.
Right
That's
wire.
the next command.
I need a lot of G now.
Sen burada gelsin. Sen de
I take it. Yeah.
The wrong way. Okay.
Right wire ik in de dood. Dat is voor een nummer schoenen.
That's 7 millimeter. So
That is 7.
7 mm. Dat was ik stap in de
Do your part, Miguel.
not of the team necessary. Team representation. So we go through slightly. Now have a look here. We are 25, yeah. 20 centimeters. Ahead. No, I have no. Now I have a little bit, but I think it's proper. Yeah, I don't know where I am. 25. Okay. Now 50 we take the next one. A little bit less. Not good.
That needs to be more stiff.
Give me a 9 one.
En nou?
9 millimeter.
Dat wordt nog millimeter.
From the mat, from my mat. From the mat, from my There's something
I
you
don't
want
know
to
now we have a kind of feeling. But yeah, this is a method of feeling.
Yes, yes.
Yeah? Because we do this outside, it's not easy, yeah? And you see the booties are not a good shape. Tanja, die eigentlich, kann man eigentlich gut vergessen, dass man das nur gebogen bleibt. Also,
Matthias, du weißt, du
ja, weil sie
du hast sie
because the transport was in my luggage, and it was the flex. So this maybe this was my pity, yeah. And this is the reason why it's not easy to put downstairs. Yeah, okay. Hold. Hold. Draw, back to wire. So, okay. Yeah. Okay, more, draw. Okay.
Is it done?
More.
Okay. But this is the first. We're going on 55.
Better now? Okay. Ist der besser? Der beraten
sind natürlich in der
The problem of the bushies was the transport. They are a little bit old, they are a little bit flex in my luggage, and now we have a problem, they are not rigid enough. Oh, I try very softly now, because it's a little bit dangerous for the patient. I hope this one is a bit better shape. Hast du da ein bisschen was reingespielt?
Ja, ich hab
Der geht besser, der geht besser.
weil du gesagt hast, ohne Wasser geht's auch.
Ja, normalerweise geht das, ja. Ah, this one is better. Okay, very good. 45. So you put this the wire. So 45 is so I would now hopefully we can pass now. Then I would be more happy to try in the correct direction.
That's what we're second before.
Can you switch off the light, please? Okay. Here's the problem. Now the problem on 30 centimeters. Here's the problem. This is still a problem. Here is the problem. We have a small laceration over there. The block.
There is a place of dilatation. Yes?
Okay. Give me the wire again. I try the 31 one. But normally, maybe I started with two less. So the rule was a bit more. But normally I don't use more than 2 sizes. This is the rule from Zavali. That's the Zavali system. And we're using this to try now, this is 31, huh?
He's trying to
31. One moment. Put out. Last one was 11, huh?
You trying again, Dr. Matthias?
We try much more. We use now 13 millimeters. 13. Ja, 12,8. Gut schmieren. Ja, super. Gut schmieren, gut spülen. Das läuft. Yes, it's a very, very, I think, bone and a lot of fibrosis. And now das ist besser. Jetzt werden die besser. Die werden die Lagerung. Ja. This is more rigid. This is the better one. Yeah. Okay. Please draw. Draw. Okay, now it's fine. Okay, so okay. We are over the 20 So we go out again and we check it again with a gastroscope. I hope so. Did you pass any time?
No.
No, you don't.
You mean in stomach? No.
Yeah?
No.
Never. Oh, not easy to pass. Yeah, but we can. Okay.
Little.
Hey, dangerous. Yeah, dangerous. Yeah.
2-3 sessions.
Yes.
I think it's much better.
Measure. You could stay here. No, we're only after this is now what is fine. Two positive after only two. Right now nothing. What's it? No? Ja, klar.
Wenn das geht, da.
Any idea what the solution is?
So, I would start to do it in this case. 10 days.
Dr. Sender, tregona pak procedurën ta shka po doni me bo.
Okay. You have seen it was a very, very severe stenosis, and also with the bushes, it did not pass. But for this time, I would not use more because you have seen we have some laceration of the esophagus, and there's a big risk of perforation. The risk is about 1 to 2%. And we decided not to go ahead. Yeah, because as you have seen, I tried it with to go through with the endoscope, and this was not possible. So be careful. Yeah, be careful, and this patient has to be checked in the afternoon. Yeah.
Do you hope that finally will come in
Yes.
the stomach?
I'm sure you will come. I would start next time. We will let you the bushes here and also the wire. You can use it again, and then do it very careful. This fluoroscope would be much better, I can tell you, but you can try it very carefully. Put the wire inside, Abri or you, and start, I think in this case, with 9, 11, 13, and then carefully with 14. Not before 10 days.
Okay.
And check it again, and maybe she needs several times, because in these cases, also bushy treatment you have to use very often, very often. I had cases, I have done it 100 times. And this is fibrotic cases, she needs it again, I'm sure. Okay?
Okay, thank you.
So we did not take some biopsies now because I think this was very stressful, and I don't want to harm her because you have seen, we have seen a lot of laceration, but don't forget maybe take next time some biopsies. Yeah.
Nothing, eating, drinking, nothing 6 hours, till 6
Is-
o'clock.
Yes.
It's really
Is
important.
there any place for surgery?
No place for
You believe
surgery.
that we
Yeah.
Next step is another bushing, Dr. Matthias.
Yes.
2 or 3 sessions.
After 1 month, some
No, not too late. 10 days.
10 days. Okay.
10, maximum 14 days. If you have a severe peptic stenosis, I do it every 3 days. But in this case, I would stay a little bit longer. Yeah. If it's a peptic stenosis, the most important is to do it very often, every 3-4 days. In this case, with a very old, severe fibrosis and without fluoroscopy, this is a problem. Without fluoroscopy is a risk. Or nurses, I can't tell you. This is a very noisy lady also talking. Then, if it's peptic stenosis, you can try it really every 3 days. In this case, I would do it not so often.
that is septic.
No, no, it's another disease. It could be maybe ingestion problem because of maybe some domestos or like that kind. All this is a kind of severe eosinophilic esophagitis. So also discussion about steroids could be a discussion, but without this diagnosis, I would not do. Next time, please take the biopsies for eosinophilic esophagitis and Lichen-Ruber. Did she have some problems? I have seen she had very eczema on the hands. Maybe she has some dermatitis. Maybe we have to check it. Yeah. Yeah.
What about medications? Is there any place for
PPI.
only PPI?
At the moment, high dose, I would give twice a day high dose. It's Pantoprazole, for example, in the morning and the evening.
Nifedipine?
No, it's not the case because it's not a spasmos. It's I think an inflammatory esophagitis. The reason we don't know.
What about the corticosteroids?
At this moment, this is a risk for perforation. No. Also, installation of local steroids is not a good deal. Maybe it's for topical, but for this you need a diagnosis for the budinosid Jovesa, as you know.
Doktor Stendera, bën një lutje. Se në zonën nuk po dëgjohet mirë, kështu që veç po dojmë 2-3 serime. Domthon pika e parë është lëndu pak ezofagu, apo sa e pam? A çështu?
Oh, yes.
E dyta, tash po dojmë, a ka nevojë për shembull tash me bullkësancën e dytë me sa dite, preferenca i rekomandimi juaj, dhe treta, a ka nevojë për stent me gjithë ma vona, çështu? Se t'ja ose Hajde se spodëgjohet mirë tash.
Professor Matthias, may I ask something? Just a moment, please. Please, I'm sorry. There is a question. There is a question. First question was after how many days? As I understand, you said after 10 days, we'll try again.
Yeah.
First, second, is there any place for stent?
There is indication for stent, but then you need a special stent. You need the ultra flex, the very rigid system. They have also a high number of degradation, and I would not do this in this situation. I think with a conservative method and over a longer period and very regular, yeah, she has to come very often. You will have more success. Yeah? And again, we have not a good diagnosis at the moment. We are treating only symptomatically, and we have no really diagnosis. Yeah? So please don't. I recommend that you take some biopsies next time before you start with Fuji. And maybe in the upper part will be enough diagnosis. Not in the 30 centimeters. I maybe take biopsies of 20 and 25 centimeters. That's far away from the stenosis. And then nothing can happen because of the biopsy.
You mean from normal mucosa?
A little bit above.
Okay, thank you.
The diagnosis also, Lichenhuber-Planus, you can also. I think this is a Lichenhuber-Planus. This was a rare diagnosis I showed in the foreign body.
Okay.
Interesting cases.
Yes, very and difficult cases. Interesting. Thank you, Dr.
So next case is now we hurry up. Hopefully we will not harm anybody. This is always a problem in the live demonstration. Yeah?
Till now it's very good. No problem.
Cases.
No, polyps, different sizes.
Oh, what is the age?
Next patient is male, 62 years old. I think on December 2022, he was here from
Abscess.
Yes, abscess, perineal abscess, fistula, and colon polyposis. As polyposis coli. As I remember, he underwent polypectomy, and we one session of polypectomy. Yes.
Different sizes, 2
Yes.
centimeters.
And now
we will do another session with polypectomy.
And we are going to do polypectomy without, I don't know if polypectomy with. As I said, I don't like anesthesia here, right? Okay.
Oh, the bowel is good prepared, I think so. Much better than the other one. He has no diverticle, but I did not find any polyp at the moment. There's small polyps. Maybe we can remove out. We do the French situation, yeah. The French people, they take the polyps out when they come. Yes. The nice one. Okay. I think this is a good kind. This could be also be removed out with a cold snare. Do you have cold snares?
We have normal snares and we call it cold snare.
No, we take cold snare.
We don't have special cold snare. We have here? Yeah. It's a good. Okay.
So we just talking about the snare types and what you have, and you have also, I think, the right one. My head nurse Tanya said. So we try to remove everything out with cold, without any high frequencies. This is a small one, and you will see it's easily done. I think there's another one over there. Okay. I think it's not easy to perform the endoscopy with. Yeah. Oh la la. Okay. So he is rich, this man. He's rich, and they have been. Oh la la.
I think it's enough.
Go ahead. Maybe go ahead, because we are still on the left side, no? Okay, then we start from the. I would take out everything with a cold snare.
Everything with cold snare. Let's do it.
Tanya, what do you think? My head nurse, she says yes, because it's easier. And I always do what my head nurse said. Yes. No. If you do cold snare, no injections. This is the reason.
That is the reason why we call it cold.
Cold, because there's a small. You look, this is a small here. Peduncle, yeah. Small peduncle, the size. What do you say about the pattern?
Just a second,
Stop.
just a pattern to see. It's adenomatosis or hyperplastic or ovulovilose, depends on the pattern.
Just one short moment, and to put the chroma endoscopy over, go nearly on. Okay. Let's look. Okay, nice. This is three. This is a low-grade dysplasia for sure, and yes, the Paris classification is not needed. Okay, change
the line.
Okay, if you
Change the line.
If you stick with pattern 1, do you resect it or no? What? Pattern 1. Pick 1 and 3. 3S, I would say 3S, because you see. Yeah, 3S. This is 3S. Cold.
quite the same, huh? Yeah. What is your age?
52.
Yeah, I'm 59. I'm getting 60 now. Yeah. Yeah. So we are happy. This case looks a little bit easier than the cases before. Maybe would be next time we do it another way around, getting warmer, and then we are hot. Now we take the cool down way, huh? Go to from the left side to the right side. No, now we'll do it from the other side. So from the left to the right. Now it's fine. Yeah, fine, close. I had close. Da ist ja noch welche da hinten.
It's finished. It's finished. You take it out later.
Wir haben keine Saugungsteile. Was das mal, das zeigen wir dir nachher. Das wird zu viel. Ja, aber jetzt geht es darum, wir wollen das schnippeln. Ja? Oh, this is one not for cold. No, this is one, but this one is too large for cold, I think so. Yeah, but this is too large. In this case, is this a hot cold or is this only cold? Then I would put it out with no, I know. No. I would
I don't know.
No, this is a hexagonal snares. This is sometimes they are not too easy to put on the. Yeah, draw it back. You have to draw the polyp down. Right. Take it and take it down, and then you have it again. Dass du den runterziehst, weißt du? Ja, den runterziehen.
Behind the phone. Behind the phone.
Yeah. Oh, there's a steel, huh? Pentaculated, yeah. It's a little bit.
Besser den auch.
Also,
No, but I think the hot snare.
hot.
Yeah, hot snare.
Okay.
Okay. Good.
To make it a little bit faster, yeah.
Close.
Yeah, no. Yeah, it's good.
And now I'm going up.
No, to have to see. You have to see the bottom.
Okay, good. Now you're
And a little bit down, because you have not everything inside. And take a little bit down. Because assistance can help also a little bit.
Okay, yeah. Can we try?
Yeah.
No. Close. No. Huh? No.
No, I'm not happy. I'm not happy about that.
Open finger. Please open. Now it's
You lost it. Ja, das ist gut. Jetzt runterziehen.
one part is always now close, open please.
Nein, du hast nicht alles drin. I show you. I would be another way. I think the problem is of this one is that the snare again is not good working. Yeah, because it's a hexagonal snare. And it's also a little bit quite to come in this position. Yeah? Over there. No. Please hold like this. Was machst du mal so?
Okay, wie das dann?
Nee, wir haben den nicht das hier. Komm mal auf. This is one problem with the snare. This thing.
Okay. So.
Now I go up. You want to see this here?
Nein, weiter.
Here's the bullet. And where is the point? I think the problem was for you the hexagonal.
Yes.
I don't like. Yeah, a round snare would be better in this case. And this was difficult for me also. You maybe have seen. Okay, do the next one. There's a lot of. Maybe you have seen the choice which snare you choose is not easy. Yeah, in this case, we wanted not to use another snare for costs, and because it was a hot and cold snare, and these are mostly hexagonal snares. And for this petriculated polyp, a round snare would be better. Yeah. So this. Siehst du den Polyp da überhaupt?
This is an old one. This is one you cut it and you went up and not down. This was one polyp before and you want to was wollt ihr denn machen? Du hast nicht zugemacht, du musst zumachen. Jetzt. Uiuiui. This is a case you have to perform more often, I think. Do it in one way. If you have so many polyps, you can't remove every polyp in one session out. It's not possible. It's time consuming for you, for the staff, for everybody. So mostly I start with the right side, and when the right side is done, I take another session 6 months later and I remove the other side out. Don't use in one session to have the need to do everything. Yeah? At the end you don't do anything right. So start up, remove the one side, and then say to the patient, okay, if you go to the dentist, he will never do everything. I say, this is my yeah, and maybe we made some parts, but not every teeth. Cold one is good. And then beside another one. Our hero is a good performance now. There are more polyps. I think this patient is for the next autumn workshop also.
Dr. Matthias, you use cold or hot snare? Cold.
This for the others we have done in hot. Maybe you have seen this. So very good. Zack. So this is done. This was just beside this. I think, from my experience, this is too low.
What you'd like this?
I will go where you see. You should go upward more with. Yeah. This was the reason I thought you need a very good one, because this was a gift from our Rotary Club. From my Rotary Club.
Okay, this one and finish.
Oh, thank you very much.
So cutting is not the whole problem. Now we have to collect everything we have done. It's just like you're in the garden, cutting the trees is easy, but to take the wood makes more work. Huh? So I think this patient should be careful. He has a big advanced risk for cancer. Yeah. Oh, the chief is coming, so we have to concentrate more a little bit, not talking so much. We show you later, my friend Skender. We have a special tool for you with us, but we show you later. Then you have it's not any longer to remove it in this way out. You can just suck it, and you have this tool. No, we show you later. Well, do you have such tool?
Yes, we have it.
Oh, so?
Yes.
Why don't you use it in this case? I have the feeling you have more than you think, huh? Because it makes no fun for the doctor to collect the small pieces. You're getting crazy. And then you have a side, yeah? Okay. So, but please tell me, Skender, which part of this, there's another one, which part of the colon you have now cleaned with polyps? The right or the left side? Or you are between? What was your concept?
Right now, today?
Yes.
It was from right to left.
Because I just said it's better to clean one side. Maybe only the left side or the right side. Yeah, and not something between other.
Only left.
Only left.
Only left. Here transverse column.
And what kind of polyps were histologically detected? Only low grade and not serrated?
Can you see where is the place with previous?
Yeah, I see a snare. Yeah, I see. Just look carefully back.
Take the pieces of the removed polyps and it's okay.
I think in this case, here there are some polyps. No, anything of them were cancer. So I think to remove out one, for example, is also enough.
It's just an avoid.
Yeah, it's time consuming. Yeah. And only the part and only.
Tell him to put it in the bottom and bring up. Okay.
Yeah. But this small one, yeah. The small one. What he needs the next follow-up colonoscopy. Every year.
Thank you.
So you have seen this case. You are happy about this case? Much easier than before, but in this case, I think very important. The follow-up, as you know, it depends on, now we have no guidelines in Switzerland, depends on the number of polyps and the size of the polyps. And if it's really a polyposis, yeah, it's for more than 20 polyps you remove. More than 20 polyps. So it's probably no family history of cancer. So this is an attenuated polyposis probably. Yeah, an attenuated polyposis, and it needs a follow-up minimum every 2 years.
Professor, we prepared, I don't know if the patient is here, but we want to consult one patient. She's around.
No, we just want to finish this.
Okay.
We want to finish this patient. Sedation was very good. The anesthetist.
Very good.
Thank you so much. Yeah. Thank you for sedation. Thank you so. Mir. Yeah, without sedation we can't do good colonoscopies in this field. Yeah, this is much important. Yeah, and everything fine. Patient is also happy. You can see he is laughing. This is a good prize for us. Huh? This maybe Tanya, please show this for the audience. Tanya has here a tool you can see. This is for collecting the polyps. You put it between the suck machine and the endoscope, and this is easy. It works very easily. We show you also later live here. You can see it. Yeah, and you suck it through the endoscope, so it's not necessary to pick it up with a snare, and you're losing so much time.
Generalmente ci muovesco clicato per tutto c'era interessante. C'è tutto
So now we come to the final patient, I think so. And Abri will tell you something about the patient. This,
41-year-old
Dr. Albert prezentă Rastin.
41-year-old male. He came for dyspeptic syndrome, reflux disease, gastric discomfort. He has done 1 month ago routine gastroscopy, and we noticed polyp in the esophagus. So we are doing gastroscopy to review this procedure, this case, and to see what we can do with these 2 polyps to evaluate the pattern and everything. So Dr. Matias will do endoscopy and will check the size and the polyps and to remove it, all polyps. I think 1 or 2 polyps were. 2 small polyps. 2 small polyps in the middle part of the esophagus.
The nurse said they have fun every day this week. Huh?
I have done this before.
Flowers, yeah. Huh? Spring. Yes, spring. Now, yesterday was Women's Day, huh?
Yeah.
Yeah, it was yesterday. Wednesday. Oh, crazy day. Crazy day. The whole year. Well, we go.
I think it was proximal. Okay. Upper, put that up, or it's okay. Proximal part of two points.
Maybe it's papilloma. Yeah. Maybe
Yeah. We will remove it.
Oče,
No.
a ty se učíš podívat věci. Jsou fakta.
This one, huh? See. This one.
Yeah.
It's a papilloma.
It's
It's a papilloma. Yeah, you see this? This is papilloma. This is not a cancer, but the situation, and he suffers on reflux disease.
Reflux.
And just have a look. Here's also here a little bit inflammation. You see, did you moved out? H. pylori was ruled out.
Yes, it took triple therapy.
Okay. So now we are on the deep pass 3 of I go a little bit back. On the, you see some inflammation, maybe also some Yeah. He has also no hernia. Yeah, looks normal. So this is not really this pain. Maybe he has a non-reflux disease. Yeah. Yeah. So what shall we do with this small polyps? Yeah, I think we in this case, what I see here is also some kind of candidiasis. It's immune deficiency. HIV.
I think something. Yes.
I think something happened.
Something. He is musician, I think.
I think he has. Yeah. He is esophagitis. Yeah. You see, that's like candidiasis. Yeah. You see. There's something else, yeah, with him. I think maybe he's HIV or what else. You see here. This, yeah. Yes. Sorry.
Okay.
And
so,
this here.
To leave it or to remove it? What are you doing?
Promo endoscopy is here. Yeah, it's easy to move out. It's not a problem. Yeah. In this case, I would take some time. Yeah, for this conversation. Do we have the large one? Haben wir die große, die haben wir dabei? No.
Aici, pominat biopsia, popas.
Pominat biopsia, ok. A nuk po don me hje krejta, po? Mish biopsi?
Tipit papillome.
Po, ok.
Okay.
You see, he is also slightly esophagitis, yeah, with candidiasis. So we discussed just maybe he has also some kind of
Immunodeficiency.
Immunodeficiency, yeah. And
we will follow up.
I think I would put only out with this. I think this 3 or 4 biopsies is also moved out.
Excellent. Excellent.
Nothing.
Just follow up. What to do?
Nothing. Follow up. Also not necessary. Maybe he's on risk. Maybe. Yeah. But that is rule number 3. What you don't know, you have to take some biopsies. And you need a good person. You see here the white defect. This is not mucus. This is from him. He has some.
Also here.
But this is
but it's okay. It's not too big. I think the upper one is more.
Where is it? Yeah. How much centimeters? 26 centimeters. This hole open. So, take out.
Good for you, Mandatory biopsy. Always you take biopsy.
Yes, because it's moved out.
Almost removed out. Yes.
Not necessary.
EMR, yeah.
Open. Done. So this is done. Ready. Excellent. Thank you very much.
Excellent. Thank you.
Time for lunch. Thank you.
A keni gati, Dr. Arbor? A keni dhe naj rast?
E këtë mirë është shumë. Faleminderit, ha? Edhe një rast? Okej.
Edhe dyja, mori mos ka marrë programin, Este casa në shka për të qina, që shikere dhe shkopan të të dhe shkopan. Sa pare i borë dhe për të të qajë. A, più borë dhe të të qajë, po të 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 da borë të të Shoqe sa të zënë e pas, një shoqe e pas. Dore një në rozjetë, në ka shoqe e pas. Po shoqe e pas. Po shoqe e Gjuba i po të 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 shto. Do të dojë në të se ka i da bashkë më djetë, ka të Altri? Po. A tutti anni c'è qui sono nel centro. Io non tu. E mi ma si c'è più nella vita ci fa. Io ho schiena. Si fosse che c'è anche che sarà un duccio. Cosa fai? Vai c'è un po' di Ai video se che mai che c'è spazio. Siamo la costante. Hajde u tražu. Ce vrem la descopicia, eu să nu tu. Cuși, canzoni, sono la de descopicia așa de mâine. Se vei poate decizii în Andrei tehnici, ne dar stres nici n-a, mă să pun nici se chemi. Avem și eu acum. Că să-mi pune doctoresc na chiton.
Și eu vă fac.
A școala?
Așa că ce?
Ciao. Ja ne znate po što je reći. Znači, ti nas mora kopnosti. S tim ti dan što je izgledalo, čak ti je za škola. Așa că vom uita la inepție. Usko što će ce de bine? A să o vedem la? Azi, hai cam. Eu vorbesc așa că de mira asta, se gata. Și mă văd și dau ieri cu Ivona, Ai fi generoasă. Povestesc, zici, știu de toate, da? Ti arhivul registrați și dați cu șurile au știut. E că vin servicii a prigoanei. Se merge la școală. Eu știu că e o problemă. Alo. Șuiat pădare. Comandul, poi așa cu atunci se face da. Deci sarți. Se contou distante, não se acha, se dá tempo para uma eu sou da figura, Dá-me pouco, porque na acústica. Da figliare. Hai putut soara? Ai vrut să uitați de filmuri. Și șmeta și de seara noastră, să ne-am venit. Ați început cu direct, da? Augurina, să n-am de multe înainte. Hai, dar la COVID, eu am fost în Tuigrin, ia să mă duc să fac. Hai, Naida. Haide pe după absenți. Uște, cum că parideți? Că te parideți. Am avut amar. Era nu te parideți.
kvalitet på för hormonen i kulturtransmission.
Så nu typ 20 år så då var det